continue with the second part, which is relatively short. The drugs for bipolar disorder. Now, the drugs available for bipolar disorder are effective in preventing mood swings from the person switching from depression to mania or hypomania. And so in that sense, we refer to these drugs as mood stabilizing drugs. So they are going to prevent fluctuations, okay? They will keep the person at just one level within the normal range, okay, of euthymia. It won't go up or it won't come down. So mood stabilizing drugs. Then if there is also a manic episode, the drugs are also effective in bringing it down to normal, okay? And then we have some of the drugs also specifically effective in treating depression as part of bipolar disorder, because regular antidepressants are not always effective, okay? So we have special drugs for depression in bipolar. So the drugs there are lithium, also discovered by chance. This was a historic antimanic agent discovered by chance. Somebody was playing with guinea pigs using urate source of lithium. And then he found that the excited guinea pigs became calm after he gave them the lithium. That was where that one too came from, okay, purely out of chance, serendipity. So some anti-epileptics are very critical for bipolar, particularly valproate, sodium valproate, carbamazepine, and lamotrigine. They are very important agents for bipolar. Then the second generation antipsychotics too, olanzapine, risperidone, quetiapine, and aripiprazole are also useful. And then antidepressants can be added as adjuncts, or benzodiazepines when you need to control the anxiety or you want to sedate. Then benzodiazepines are added as adjuncts. So these are the agents that are available, and the list is not the arrangement, that means the arrangement of the drugs on the list is not fixed. There are variations depending on which system you are in. The British have slight variations, the Americans. We also have our own, okay? So all the drugs in each column are effective, but based on other conditions, prevailing comorbid condition, patient characteristics, particular ones can be chosen. So the treatment would typically be in 3 phases. So the acute phase, where the person can come with mania or depression. So you have to treat that separately. And once the patient is stabilized to euthymia, then you also need some drugs that to keep the patient in the stable mood so that it doesn't fluctuate. So there are drugs for the maintenance phase to keep the person in the stable mood. So in the first column, the agents for mania, lithium is there. I think commonly the carbonate. Then valproic acid or sodium valproate, or a mixture of the two called divalproate. That one, sodium valproate, is mixed with valproic acid in a ratio of 1:1, okay? That is divalproex. Then the second generation agents are aripiprazole, olanzapine, quetiapine, risperidone, ziprasidone, asenapine, and even haloperidol, okay? All these can be used, and carbamazepine, in order to bring the mood down to the normal range. Then once the person is stabilized, then you can now choose from lithium, the same Divaprox, lamotrigine, aripiprazole, olanzapine, quetiapine, risperidone, and carbamazepine. Any of these, depending on the other conditions of the patient and the other characteristics, can be chosen. And then for depression in bipolar, the popular agent there is quetiapine. Lurasidone can be used, and olanzapine typically combined with fluoxetine. Now, quetiapine is a second-generation antipsychotic, but a metabolite of it is a noradrenaline reuptake inhibitor. So it could start out as an antipsychotic, but some of the metabolites become antidepressants. Okay, so that is the unique thing about quetiapine. Then lamotrigine, lithium, carbamazepine, Divaprox. Okay, those ones are in italics because even though they can be used, they are not commonly used. Okay, so this is what we have. So in the next lecture on management, Dr. Done will tell us the preferences that we have, okay, in Ghana. So we've talked about antipsychotics already. We'll talk about the anti-epileptic agents later, either before we close today or first thing tomorrow morning. And so I only talk now about lithium, okay? So those are the psychiatric hospitals. Do we still use lithium? Yes. Grace and do we still use lithium?
Lithium is the preferred, but because the labs are expensive, when you're on lithium, you should be monitoring.
Yes.
And the risks of seizure and the organ impairments.
Yes.
So usually you fall on carbamazepine, which is the least effective.
Okay.
So plans are way advanced to get our own machine,
okay,
so that we can check it.
You can check the things.
So that people who, it's in the pipeline, so that lithium will be the first line. Well, when we did our investigation, they said that the same machine that is used in checking sodium levels,
okay,
is what is used in checking lithium. So it's a matter of calibration. So we are following up.
Okay.
If we get it, then it will become the first line in Ghana.
Okay. Well, it doesn't necessarily have to be the first line. It's quite effective, but it doesn't necessarily have to be the first line. There are others that are also equally effective. But the problem with lithium is that it is a drug with a low therapeutic index. That is the major problem. It requires plasma monitoring. That is the barrier against its use. If you don't have the equipment to measure plasma levels, the patient can easily get into, overdose, and there are a lot of complications. Okay, so that is the challenge. I have asked Courage, he says they don't normally prescribe it. And he's also saying plans are far advanced. He told me the last time. Yeah, plans are advanced to get the labs to help them for the TDM and all that. Okay. So as I said, lithium was discovered also by chance in 1949. And as at now, according to the evidences we have, it is the only known anti-suicide treatment which can reduce the risk of suicide by more than 50%, based on data, okay, from trials. So for somebody with bipolar, with a very high risk of suicide, lithium will be very useful. The evidence is there. How lithium works currently is unknown. There are several mechanisms ascribed to lithium. Lithium does a lot of things in the body. We are not so sure which of those things is responsible for its action, okay? But the speculation is that it's very likely going to affect one of the mediators in neurotransmission called ionocytol triphosphate formation. Okay, that is where the most people think that is where the effect lies. Okay, it inhibits some kinases like GSK3, glycogen synthase kinase 3. I mean, it does a lot of interesting things. Okay. Now, when you take it in, there is no problem with absorption, and it is widely distributed with no metabolism or protein binding. It behaves just like sodium in the system. Okay, it's taken up by sodium ion channels, and it goes round. And so because of that, elimination can be a problem at times. In the kidneys, it is reabsorbed just like sodium. So it lingers in the system for a while when you stop administering it. The adverse effects are many, but these are a few important ones. GI issues, nausea, vomiting, diarrhea as usual. And then there's a problem with ADH. It interferes with the actions of antidiuretic hormone. So after a while, you begin to pass a lot of urine, and therefore you have to take more. Okay, so polydipsia, polyuria, and polydipsia. If this continues further, the toxicity continues further, then you now have frank nephrogenic diabetes insipidus proper, where you pass out lots of dilute urine, okay, because of the effect on ADH. It also affects the actions of the thyroid gland. The thyroid stimulating hormone, in particular, it affects its function. So occasionally, the person's thyroid gland might begin to enlarge, okay, but that is reversible if you discontinue the treatment. Then there will also be fine tremors, mild cognitive impairment, hair loss is also another issue, something that will be difficult for females to bear. So you have to take that into consideration. Weight gain is also another one. Now, the key drug interaction when it comes to lithium is the competition with sodium, okay, in the tubules. I said that it is taken up by sodium ion channels. So in the tubules, there is competition between sodium and lithium for reabsorption. So if you create a state where sodium levels are low in the body, you give a lot of chance for more lithium to be reabsorbed. Are you following? So drugs that can create hyponatremia would increase the risk of lithium toxicity. So things like diuretics, thiazides, loop diuretics, in fact, AC inhibitors are also known to do that. And so you have to take care of, when you are using those agents together with lithium. Then some NSAIDs too are also able to reduce its clearance. Indomethacin is one. And so we should take note of that. Then toxicity again, lithium is contraindicated in the first trimester, okay? It is linked to an abnormality with the heart, okay? There is something they call Ipstein anomaly, where the heart doesn't form well, the ventricles are joined together. The wall between the left and right ventricle opens up. The septum opens, so you have a connection between. That risk has been linked to lithium, even though others have disputed the validity of the data. Okay. Then it should also be avoided in breastfeeding. Okay. So avoided in breastfeeding. So the last point, the monitoring, as I said.
Please, I have a question.
You have a question, okay.
Yeah, avoided in first trimester,
yes.
But can be taken during the second and third.
Yes, after the organs have largely been formed.
Then why
I mean, if it is very critical, you can use it. You balance the risk. So why then
should this be avoided in breastfeeding?
In
breastfeeding mothers?
Breastfeeding for the child. I mean, toxic effects in the child. Oh. So that is the challenge there.
Excuse me.
Yes.
As a follow-up,
yes.
The question is, if if it's okay for an infant or a neonate, why is it okay for a second trimester and a third trimester fetus?
Well, we are talking about risk benefit.
Okay.
Yes, risk benefit. If you need to give the lithium to the person, then restrain yourself for the first 3 months, then thereafter you doesn't mean you won't possibly make it, but mothers well. So if you want to use lithium, as we are saying, get the equipment to monitor the plasma levels. Therapeutic drug monitoring is very critical. The normal range is between 0.5 and 1 millimolar. Anything above that, toxic symptoms will appear. If it's lower than 0.5, you don't get a therapeutic effect. Okay. So all these things can be monitored. Beyond 25 millimolar, 2.5 millimolar, seizures would appear, and there can be circulatory collapse and coma. So treatment will be symptomatic. We discontinue the lithium if toxicity occurs. Hemodialysis can be useful in reducing the plasma concentrations of lithium. And then when seizures appear, you use anticonvulsants to deal with them. Okay, and then hopefully the system will be cleared of the lithium. Okay, so this is the end of the presentation on the bipolar agents. If you have any comments, questions, any comments or questions? Yes.
I think your mic is working now, so.
Please, it looks like the side effects are many for lithium, but I may not want to say that all are significant side effects.
No, not all are significant.
So which one should we keep in mind? Because
okay, I now get your question. Which one should you keep in mind? In fact, all the ones here are important. Because there are a few others that are not important, so they are not here. But the ones that are appearing here are important. They are important.
Maybe we want the examinable side effects.
Yes. No, you can easily break this down into GI problems, kidney problems, thyroid problems, cognitive, okay? And then hair loss and weight gain, you can always remember. So just group them and you remember, okay? So it's not so hard. All right. So any other comments?
Yes, let me comment on the question on the adverse effects,
Okay.
all right? So all clinically relevant adverse effects, some of them have been highlighted here, but a lot more we need to read about it and get to know about it, you know. So don't only think about the exams, think about the patient, okay?
Yeah. Okay. All right. Dr. Done will join us at 12. So because of we want to maximize the time, so I will bring my anti-anxiety drug lecture now, so that when he comes in, you just do a marathon till we end. Okay, because we have to look at the management of depression and bipolar, anxiety and management, and epilepsy, introduction to epilepsy. Then early tomorrow morning, we finish up. We have to leave here before 11 o'clock. There is another group that will come here. Okay, so we have to stay and finish so that tomorrow, we'll be free.
Point of correction is after 11, not, yes.
After 11, okay. All right. After 11. So we have up to 11 o'clock. Okay.
So any questions on the previous discussions that he had before you move on to the new topic?
Doc, in the list of drugs for bipolar disorders, I saw that a couple of them ran through. There was lithium, there was olanzapine, there was another one. For both depressive, mania, and then there's maintenance. So in this case, if you want to play safe and decide to, say, start with only olanzapine and go through,
then it will run through. Yes, that can be done.
Okay.
I mean, you can do that. Okay.
All right.
You can do that. But, you know, there are other considerations, as we said. So if you find that the patient has some other conditions that will not permit an antipsychotic, then you have to try something else. So, I mean, right. So before...
Hello, excuse me.
Yes.
On the same bipolar. Did I get it right when you said the treatment is in 3 phases?
Well, not in 3 phases, maybe 2. You present with an acute phase, and then that is managed in a maintenance phase. Okay, so the first can either be acute mania or depression. Okay, just that when you present with depression first, if you don't have any history of mania, then it will be very difficult for the clinician to be able to categorize you as bipolar until you show a manic episode. Are you following? So if the history doesn't show you had a manic episode, very likely they may say you are just depressed until the manic phase appears. Yes.
In talking about the way depression happens, saying that there's not enough of the neurotransmitter, and so you take the drugs to up the... But normal people do get depressed. It may resolve spontaneously. Are we saying that during that time of depression, you know, that same mechanism is happening?
I would... maybe you shouldn't use the word normal people are depressed. Once you mention depression, that is a problem. Okay. But our mood swings.
Yes.
You see that the thing was a range. You see, it was a range. What is considered normal is a range. Euthymia is a range. Okay? And even maybe because of time, he didn't mention at the upper limit beyond which you become pathological, there is what is called hypothermic temperament. There are some of us, even though we are normal, we have a lot of energy. So we are very close to the mania. You see, so naturally you find that some of us are talkative, we are very active, we are all over the place. You know, we have some small grandiosity, and we think we are very, those things are amongst us. But normally it's within the limit, so you are also normal. At the bottom too, you also have melancholic elements, okay? Depressive temperament, people who always look sad, as they have some burden, they are always in some corner, they don't interact much. They are also there, but they are also in the normal limits, okay? So outside of that, then you are pathological. So our mood swings. It is not a specific thing. So we say mood is a spectrum. So depending on the time of the day, or your mood can fluctuate. But it fluctuates within a normal range. It doesn't go beyond that. So the normal processes of the mind would allow for such fluctuations depending on how the transmitters are working and that kind of thing. Thank you.
Dr. Bochi?
Yes. I want to find out, looking at the treatment of the acute phase and then the maintenance dose, for certain conditions, we realize that the dose of medicines during the acute phase is usually very high, and then maintenance dose is reduced. So for these medications, is it the same or?
So those things are possible. Yeah. If you choose, like he was trying to say, if you choose an agent that runs through, you may probably, in order to quickly control the thing, you may use slightly higher doses. And then after some time, you reduce it, hoping that the symptoms should not show. And then eventually, after some time, you may want to take the person off for a while.
Dr. Boja, I was going to ask, those who are hovering around both the upper and lower limits, is there an indication of that, the fact that they have some risk or increased risk of sliding into other, the beyond the upper limit and below the lower limit? Is it a risk factor?
No, I am not sure. So when Dr. Donet comes, then we ask you. I'm not sure about that one. You see, but what I know is that there is a whole lot of people, even above the hyperthymic or the depressive temperaments, who have some symptoms, but they do not qualify for the next diagnosis. For example, if I say next diagnosis, below the depressive temperament, the first pathological state is dysthymia. So between dysthymia and depressive temperament, people may lie there, but their symptoms do not qualify them to be classified. So they are subsyndromic. Those people are also there, okay? And so their risk, I know, is higher, but for the normal range, I'm not sure, so we can ask him, you know, if he comes.
One question here. Pablo is asking me some difficult questions. I think it's better you answer.
I was asking about when they say somebody has two personalities, can it be considered as bipolar?
No, it cannot. It cannot. That is different. That is different.
Please, we didn't hear the question.
No, he's talking about people with dual personalities, and there are conditions like that, but it's different from bipolar. I don't have much to say about that now, but I know for sure that that is a condition. It's a condition I know differently from the classification of bipolar. Okay? Mm-hmm. And that condition, normally, people even try to confuse it at times with schizophrenia because they were referring to schizophrenia as, say, split mind. So split personality and that kind of, is different from bipolar. Mm-hmm. Okay.
Hello.
So, okay.
I wanted to pass a comment with the question he just asked. I was thinking that people with two different characteristics or characters, some are deliberate. But with the bipolar, I don't know if that's not deliberate.
No, it is not. It is not deliberate. Bipolar is not deliberate.
No, yeah, I'm saying that is not deliberate. But people with dual characteristics, sometimes it can be deliberate.
It can be deliberate.
Yes.
So, okay. Yeah, it's also a problem on itself. if you want to assume two personalities, it's a problem.
This will be an interesting discussion when the psychiatrist, all right,
comes.
you know, so we can talk more about this. All right, so can we move on to the next?
We can move on, okay. So in order for you to be able to relate with the drugs, I'll have to do a little of Dr. Donet's job by explaining what the anxiety disorders are, okay, and what groups are there. Then you know the medicines that are there for them, okay. So when we say anxiety, I mean, what does it mean? Let me ask you, well, what do you think anxiety is, and how is it different from fear? Yes. Anxiety. Anybody?
I think
okay.
Where it's a condition whereby the individual becomes extremely anxious. Or
yes.
Okay. An attempt.
Okay.
Yeah, I think
anxiety is fearing something that is not there. And fear is fearing something that is there.
All right. I think the idea is there. I mean, the idea is there. So anxiety is an unpleasant emotion, okay? A vague one, which you experience in anticipation of some future misfortune, okay? You are anticipating something. The threat is imagined, and so you are apprehensive about it. So fear, the threat is real, and you can see it, that the threat is here. So when you express the apprehension is targeted at the fear that you can see. For anxiety, the threat is imagined. Okay? It is not in the environment. It's something you are thinking in your mind that, hey, this can happen, or then you become excited about it. Okay? Now, anxiety is good. It is important for survival. Just like pain is important for survival, anxiety is also important. It's an adaptive emotion. It is anxiety that charges us to pay attention to threats so that we can deal with them. Okay, so it's very important. And so it's a warning system about threats so that you can prepare yourself. If there is no anxiety, you very likely fail your exams. It is the anxiety that you might fail that is what pushes you to study. It's very critical. Yes. You see, so there is a performance chart here. You see the link between performance and anxiety. If your anxiety is too down, you are not motivated to do anything. But as it goes up, then it puts some energy in you to deal with whatever threats that you are imagining or seeing. So it charges you and prepares you to deal with it. So it increases performance as it rises. But it gets to a point that it becomes too much, and so performance begins to drop. So you become too anxious that you are now distracted by the symptoms. The symptoms are worrying you. They are preventing you from concentrating and improving at your tasks, to the point that it's so bad that you virtually cannot do anything again. So the same as without the anxiety at all. Okay, so it is a U-shaped effect. A little amount of it is good to prepare you to perform, but it gets to a certain limit that it becomes too much and excessive, so it affects performance. So when the anxiety goes beyond the limit where it is acceptable and useful, then it becomes an anxiety disorder, okay? Where the anxiety becomes too much that it affects your functioning, your productive activities, then it becomes an anxiety disorder. And these things happen when the system that controls anxiety becomes dysfunctional. It becomes dysfunctional, and so you have a heightened response to, threats perceived or imagined. Okay. So anxiety disorders are a group of conditions that share the feature of excessive fear or anxiety or related effects, related disturbances. And so they can be primary or they can be secondary. Secondary due to some other medical condition or drug-induced. There are a lot of drugs that induce anxiety, okay? So the primary ones are the ones here. The DSM-5 has knocked off two conditions that previously we classified as anxiety disorders, okay? Obsessive compulsive disorder and post-traumatic stress disorder. They are no longer considered anxiety disorders according to the recent diagnostic criteria, okay? And then they have added two new conditions: separation anxiety disorder and selective mutism, okay? Then the other ones still remain. In separation anxiety disorder, typically in children, they are afraid of being detached from an attachment figure, okay? Their parents or their guardian, or they are afraid that they might lose that person. So they are afraid, they don't want to go out. Probably if they go out, somebody will kidnap them. So they won't be, they'll be detached from the person, or a vehicle might knock them or something like that. So that affects their performance, okay? Then selective mutism also would also be common in young people. The person doesn't speak when he or she is expected to speak, but is freely speaking when he or she is at home, where he or she is comfortable, out of scrutiny. Like in a class, you expect that the students will respond to your questions freely because there is no intimidation. But the child doesn't respond. But at home, he or she is fine. I mean, talks a lot. But when it comes to the classroom, the talking is suppressed. Selective mutism. Okay? Okay. Then social anxiety disorder, where the person is anxious about situations where he or she might come under some kind of scrutiny. Performance situations where he or she might come under scrutiny, like doing a presentation. Somebody will be looking at this guy crying, he doesn't know anything. Look at the dress he's wearing there. You are imagining that people will be saying things about you, you'll be scrutinized. You go to a chop bar or restaurant, then you'll be imagining. Someone say, look at how he's using the cutlery. He doesn't know how to. Look at how he's eating there. You are imagining that people are thinking like that about you or looking at, so you are anxious. So what is the solution? Avoidance. So you don't want to stand here and present at all. Or you don't want to go to the chop bar to go and eat. Or if you are eating, you hide in a place where nobody will see you in order to, the things you are imagining to happen. Okay? So that is social anxiety disorder. You can look at it as a pathological form of shyness and related things. Okay. Then panic disorder. In panic disorder, the person has the tendency of experiencing panic attacks. Panic attacks are periods of intense fear. All of a sudden, the person is gripped with fear, serious fear, together with some physical signs like choking. The palpitations, the person is choking and breathless. Then they are afraid that they will die. All of a sudden, they are gripped with that fear. Okay? Panic attack. And so individuals with the tendency to experience panic attacks are said to have panic disorder. Okay? Now, agoraphobia is the fear of, yes.
With panic attacks,
yeah.
I mean, I don't know whether it's an old wives' tales where, because the person is hyperventilating, they give the a paper bag for the person to steady their breathing in it till they sort of.
Okay. I'm not familiar with that tale. I mean, I'm just a small boy, so the tales. Okay, so maybe when the older man comes, I'm sure he will relate to that better than me. So agoraphobia, literally the fear of open spaces.
There's a question at the back.
Yes.
Please,
yes.
The separation stuff,
yes.
does it only apply to kids, or it does apply?
It's common in kids, but it might happen in adults.
Okay, so like spouses, maybe.
A spouse. Yeah, so it can occur. It can occur, when you are anxious about getting detached from someone you are very attached to. I mean, and it is affecting your performance at work, at school, or wherever. I mean, you are in that category, right? Okay. Then agoraphobia is the fear of, literally the fear of open space or fear of the marketplace. The person is afraid of going outside. Okay, and this tends to be common with panic disorder because the panic disorder people are afraid that when they go out, they might have a panic attack. And there will be no help for them, or people would look at them and they'll be embarrassed and that kind of thing. So it can occur together with panic disorder, but it can also occur on its own when you are just afraid of going out for some strange reasons. You don't want to be in a queue. You don't want to be in a closed space. You don't want to be in the open space or marketplace with people, etc., etc. Okay. I knew somebody when I was young who comes out only at night. It's always in the room. When you sleep by 8, 9, then he will now come out and do his activities. Then he goes back.
Yeah, Dr. Boche,
yes.
This thing that you are describing,
yeah.
Does it occur in vacuum, or it may be as a result of maybe previous experiences?
So this is primary. primary
so it just occurs?
Yes, so it just appears in the person. So this is a primary disorder, okay? It is not because of something that the person has done. The person just developed, of course, based on environmental influences. But the person just developed it, not secondary to any other condition. Okay.
Referring to things like panic disorders, sometimes previous experiences that you have had may predispose you
to having the.
Yes.
Oh, okay. Okay, I get your point. That is more about things like post-traumatic stress and things like that. Okay, that one is different. Yes.
What about claustrophobia? If agoraphobia is...
Yeah.
And what about claustrophobia?
Yes. Fear of what?
Smaller
spaces. So that one would now fall under specific phobias. So the specific phobias are intense fears for particular things or particular situations. Aerophobia, fear of flying. You never take an aircraft. It's a flying coffin. You know, the plane will crash. That is the person's anxiety. Okay, or crossing over a bridge across the road. They would rather take a vehicle that will take them around it rather than crossing. You get it? So specific things, fear of snakes, fear of spiders, etc., etc. Okay. And then the last one is generalized anxiety disorder. Here, there is worry about several things in the person's life. Work, home, children, everything. The person is just worried. Okay? Together with physical symptoms. Okay, for a period of about 6 months, the person is experiencing this thing. So, so these are the groups. Obsessive compulsive disorder was an anxiety disorder in the previous diagnostic test, DSM-4, but it's no longer. Essentially, what happens is that the person has some thoughts, what are called obsessions, intrusive thoughts that create anxiety in the person. For example, some people are obsessed with symmetry or cleanliness. So it worries them, and so they have to do some acts, okay, compulsions, in order to pacify that urge, okay? So if it's about contamination, then they will wash their hand every 5 minutes. That's a compulsion because of the obsession with cleanliness. Or if it's symmetry, then they are looking around. The tire you've worn, is it in the middle? They want to come and adjust it. Okay. Safety, obsession with safety. If you close your door, is it locked? So you get to your car and then you come back and shake it. Is it locked? Well, you go and come back, shake it. And you waste all your time on this door instead of going to work. Are my electrical sockets, have I turned them off? My gas cooker. You go to work, you go back home to check if your gas cooker, you know, all these things are there. But we have some of these things very mild in us, you know, as an anxiety manifestation, which is acceptable because, as we said, it's useful. But when these things become so much and they affect your productivity, then these are disorders that will require some treatment, either psychotherapy or the use of drugs. So I think this is enough. I can quickly talk about my medications. So there is an elaborate system of various brain regions that process anxiety and fear, okay? The most important area is called the amygdala, okay? That is there. The job of that area is that all the stimuli, everything you see and feel, all that information is taken in through the spinal cord to the brain, to the amygdala, and the amygdala will assess whether the stimuli is something you should be afraid of. Does this stimuli qualify for you to pay particular attention, to be anxious or afraid of it? It will make that decision. And once it is convinced that there is a problem there, then it will alert other brain systems so that you can take some action, okay? So areas will feed into it. The thalamus is what will carry the external stimuli to the amygdala. The hippocampus is important for retrieving memories. It's also important for storing memories, explicit memory. If you have stroke and the hippocampus, there are two, there is one here, one here. If they are all damaged, you have amnesia, okay? So from the point onwards, where the damage occurred onwards, you don't store any memory. Okay, so as we are talking now, if I leave the scene and appear again, you don't remember me. Everything is new. So the job of the hippocampus is storing memory and retrieving it when you need it. Okay, so it will retrieve information and give to the amygdala. Occasionally, the amygdala has already experienced the situation, and the information has been stored. So when it comes again, that information will now be sent back so that it will compare to it and see whether this is something from experience you know is dangerous for you to be concerned about. And then the cortex to your thoughts will also be fed into your amygdala. You can think about something and become afraid. The reason is that the cortex will feed in that information to the amygdala. So the amygdala is connected to a lot of places. So it will activate the prefrontal cortex here, the area of higher thoughts, so that you can decide on what response to give to the threat, okay? The hippocampus, again, will take the information and store it, and the context, so that when you meet it again, you have the experience of what to do. The striatum would help in learned behaviors associated with the threat. What to do about it, what you think about it, whether you have to run or whatever you have to do. All those things will be controlled by the striatum. So it goes on and on. The hypothalamus would connect the fear response to your autonomic system so that your heart rate will go up, you have your palpitations, you have your tremor and all that. The sympathetic system is charging up so that if you have to fight a threat, then you can fight it. So it goes on and on and on. So in anxiety disorder, there is an imbalance in that system. The balance should be between your ability to respond properly to the threat and then not to respond to non-threatening situations. You see, that is where the balance is. You shouldn't see things that are not fearful and be afraid of it. One area deals with that. Then another area is also ensuring that if something is dangerous, you are alarmed so that you deal with it. So there is a balance. So in anxiety disorder, the imbalance results in you now becoming anxious or afraid of things that you should not be bothered about. Okay.
Excuse me.
Yes.
It brings my mind to biblical issues.
Okay.
Here. Where they stated that be anxious about nothing. There's a place.
Yes.
So it means that we have the power. How do you connect this knowledge to that power that we have to be able to stop it? Yeah, and which part of the brain?
Yes, so there are a number of areas there that are supposed to. The amygdala is the area that if it's over-functioning, then you tend to be afraid of things you should not be afraid of, if it is overactive, okay? But the areas of the prefrontal cortex and the area there, the cingulates and all that are supposed to ensure that it is within its normal range. It doesn't perceive threats that are not important, okay? So if there is a reduction, so what it means is that we have to some extent some will to be able to suppress some of these things, especially if we are not clearly diseased. We have some capability to suppress some of these things. But when it becomes a disorder, at times it's more than the body's capability to deal with it. Okay, that is why you need assistance, either in psychotherapy. Psychotherapy eventually will use your own psychic abilities to be able to control it. Okay, but just that you don't know how to do it, or you need assistance to be able to do it. Right. So Gaba and serotonin, these are two important transmitters that are able to keep a check on the amygdala's, excessive activities, okay? And then there are other transmitters to noradrenaline, corticotropin-releasing hormone, and those other things there, which can do both, can help the areas that should suppress the amygdala. It can also help the amygdala to also respond properly. So the drugs that we use will typically augment the natural inhibitory system, so that to suppress the excessive fear manifestation, okay, through Gaba and serotonin, okay. So therefore, anti-anxiety drugs, among other things, will be drugs that can enhance the actions of the neurotransmitter GABA. GABA is inhibitory. Just like I showed you at the beginning, where the transmitter is released and it binds to receptors. If the transmitter release is GABA, gamma-aminobutyric acid, it will prevent the other neuron from getting excited. That is its job. So its job is to suppress nerve impulse and excitatory activities. Okay? So applying that to the amygdala, the enhancement of the actions of GABA can help to suppress the overactive effects in the amygdala that are allowing you to consider things that are not important as threats. Okay. Then serotonin too has the same inhibitory effect through some receptors, 581A and 2A and a few other ones. So the anti-anxiety drugs will be useful for patients with symptoms that produce functional disability. If you have the symptoms and you are okay with your work, it doesn't trouble you, there is no need bothering about treatment, particularly with drugs, which will introduce adverse effects. Okay, so you give the drugs only when the condition is significant enough to affect, productivity. And currently, specific phobia is unresponsive to the drugs we have. So it is treated purely by psychotherapy. Okay? If you are afraid of snakes, there is no drug you take that will prevent you from. But a psychologist can help you to overcome it. So these are the drugs that are available. So antidepressants, the first line, benzodiazepines for acute anxiety, okay, for short periods of time because of their side effects. Buspirone is there for generalized anxiety. Some anti-epileptics are useful. Some atypical antipsychotics have value as adjuncts. And then beta blockers. The autonomic symptoms when you are anxious can create a lot of distress. Tremor, sweating in the palms, palpitations. All this can affect you in performance situations. When you have to do a presentation, you are anxious and your legs are trembling. It's a sympathetic effect. Okay, so when you take a beta blocker, it can clear all those physical symptoms. You can stand within yourself, you are anxious, but it won't show on the outside. because the symptoms will be, eliminated by the beta blocker. Propranolol is very useful, for example, for this kind of things. Okay, so these are the drugs that are available. Okay, so for generalized anxiety, you can see the SSRIs are top on the list there, followed by SNRIs, venlafaxine and duloxetine. They are chosen first. Then beyond that, you can try benzodiazepines, buspirone. Imipramine is there. Pregabalin, the anticonvulsant pregabalin is there. Then down there you have the antihistamine, hydroxyzine, and then quetiapine. Then panic disorder, SSRIs again, or venlafaxine. Then benzodiazepines, alprazolam, clonazepam. Then you have citalopram, SSRI, clomipramine and imipramine, tricyclics, and the monoamine oxidase inhibitor, phenelzine. That is there. Then for social anxiety disorder too, you see SSRIs and venlafaxine. You see clonazepam, citalopram, gabapentin down there, phenelzine, and pregabalin. Okay. SSRIs are also useful for OCD and PTSD, but they are now in a category of their own. Okay. Good. So antidepressants are first line for GAD, PD, and SAD because compared to benzodiazepines, which are also commonly used, compared to them, antidepressants have superior efficacy over the cognitive symptoms, the psychic symptoms, the fear that you are experiencing. They are able to reduce it. Benzodiazepines tend to be effective against the somatic symptoms, okay? Somatic and autonomic manifestations. They are not so much effective against what you are really feeling inside, okay? And then they lack the potential for abuse and dependence. That is why they are first line. Except that antidepressants also work slowly in anxiety disorders, just like depression. So they need to be taken for more than 2 weeks. Meanwhile, you want to quickly control the anxiety. You don't want to wait for 2 weeks. So you can give a benzodiazepine together with the antidepressant. The benzodiazepine will work very quickly to control the somatic and the autonomic symptoms, okay? So by the time you withdraw the benzodiazepine, the antidepressant would have started working, okay? So they will work by activating the stress-adapting areas that will help suppress excessive amygdala activity. And for antidepressants, we know that initially they themselves might cause increased anxiety, okay? So this is why benzodiazepines will have to be added at the beginning. Monoamine oxidase inhibitors will be useful for refractory cases, okay? So let's look at the benzodiazepines. That's the only thing here, the major thing here for this lecture.
Before you go into that, Doc, can we have some 2 quick questions if there are any?
Okay. So any questions? Okay. So I can proceed. Okay. So as I said,
no,
as a question.
My question is not really about, I'm just confused. Would there be something like over bravery, where somebody will want to say, catch a moving car? We are looking at the fear part, and I'm looking at like some extreme act of trying to be very brave.
I see.
It looks like we're not quite close to the mic, so most of our friends didn't hear what you said. I heard over bravery.
Yes. I'm thinking somebody will act like catching a moving car, you know,
okay.
The extreme part of the anxiety, the fear.
Those things then will now go into the realms of mania, and because that is grandiosity. If you think you can catch a moving car, then you think more highly of yourself than you actually are. So that is a grandiosity. I mean, it is moving beyond the realms of, you know, anxiety and these things we are talking about, right? Yes.
What about those that we call adrenaline junkies?
Okay.
I mean, they go bungee jumping and all sorts of extreme sports.
Okay.
I mean,
so that one will not be a disorder. I mean, they are just activated. Their sympathetic system is fired up, and so they are able to do interesting things. But you cannot put that under a specific disorder. They are fine. Just that they have the capacity to do particular things.
I want to ask a question with regards to the OCDs.
Yeah.
Do we have classification like mild, moderate, severe, or anybody with slight symptoms just goes on to the medication?
So we will fix that in the next lecture, isn't it? When Dr. Donet comes, then I'm sure he will have the chance to tell us about those ones, whether they are severity classifications. Right. So for the benzodiazepines, they work very fast. As soon as you take them, I mean, your somatic symptoms, the tremors you are having, your palpitations, sweating and all that, it will go down. Autonomic symptoms, your BP rises and all that, it comes down when you take them. But the psychic symptoms, the excitement within you, in your mind, will not be significantly affected, okay? And so because they work very fast, they will be useful in situational anxiety, okay? When within a performance situation, you are standing here to present and you are anxious, you need something quickly to calm you down, then they will be very useful. You can't take an antidepressant for that because it won't work now, okay? Here again, benzodiazepines all appear to be equally effective. So selection will be based on pharmacokinetics and other problems of the patient. Okay.
A comment on that.
Okay.
And I don't want to say it is industry related, but
okay.
If you take something like a company like Roche that I work for,
okay,
had about 9 benzodiazepines.
Okay.
That based on the studies and everything that they've done, look at what are the indications for benzodiazepines and what pronounces what activity.
Okay.
So in that, you can see that diazepam, for instance, was positioned and used more for its sedative and anticonvulsant effect. Clonazepam Rivotril is known as a better anxiolytic than diazepam, based on evidence and that. So the moment we say all benzodiazepines are equally effective as anxiolytics,
yes,
maybe we may need to look at that.
Yes, this is in relation to anxiolytic benzodiazepines. I'm not talking about all benzodiazepines. You see my list here. Okay. Benzodiazepines are CNS depressants, and CNS depression occurs in a spectrum. You have anxiolysis at the least dose, sedation, if you increase the dose, sleep or hypnosis, when you increase the dose. Then the next phase is anesthesia, when you increase the dose, okay? So in addition to that, they have muscle relaxant effects. They are anticonvulsant, okay? And so some of the benzodiazepines are good at some of these than others. You get it. Clonazepam is anticonvulsant, for example. If you take lorazepam, important for status epilepticus. Oxazepam is not so good for convulsion. It may have that capability, but not so much. Okay, so out of the lot of the benzodiazepines, the ones listed here are very good for anxiety. So this is a subset of benzodiazepines for anxiety. Are you getting my point? Right. So diazepam, alprazolam, chlordiazepoxide, clonazepam, chlorazepate, lorazepam, and oxazepam. These are the agents that are typically used for anxiety disorders. Okay. So the mechanism, I will try and explain this. It doesn't become unnecessarily technical. What is being shown here is one of the receptors of the neurotransmitter GABA, which is inhibitory, okay? So what is depicted here is the receptor in the cell membrane of, say, a neuron, okay? Now, the job of this receptor, when it is activated, is to open and allow chloride ions to enter the neuron. Chloride ion influx in the neuron suppresses the neuron from discharging electrical impulses. So it's inhibitory, or technical term, you say hyperpolarization, okay? Right. Now, before the receptor, which is an ion channel, opens, you need GABA neurotransmitter to bind to. You need 2 molecules of it to bind before it opens to allow the chloride for the neuron to be inhibited. Okay. Now, when the GABA binds alone, the amount of chloride that enters is not much. It is enough for the inhibition, but not so much. But if the benzodiazepine binds with the GABA binds, and the benzodiazepine also has a site on the receptor. When it binds, then it allows the chloride ion, more of it, to enter the neuron. So the benzodiazepine is enhancing the actions of GABA. Are you following? In opening the chloride channel, in producing more inhibition, okay? So by illustration, if this is our channel, which opens to chloride, with GABA alone, we have, say, only one chloride ion for illustration. But when a benzodiazepine binds with it, you have 3, okay? So more inhibition compared to GABA alone, okay? So in that sense, we say that benzodiazepines enhance the inhibitory actions of GABA, okay? So this inhibitory effects on the anxiety system is what suppresses the symptoms we are talking about. So benzodiazepines are easily absorbed from the GIT and can cross membranes and the placenta. So if a pregnant woman is taking a benzodiazepine, know that the fetus is also benefiting from it. Okay? So there are implications for that. They are highly lipid soluble and tend to accumulate in fat. In fact, the lipid solubility affects the rate or the speed of onset. It's very critical for the speed of onset. Diazepam, for example, is very lipid soluble compared to lorazepam. So the speed of diazepam will be faster than lorazepam, okay? That's the advantage of diazepam over lorazepam. But lorazepam has some characteristics that make it more preferred to diazepam in a number of cases. If you normally follow the protocol for status epilepticus, you realize that lorazepam has gradually taken the place of diazepam as the first line if you see a prolonged seizure. Okay. Most are administered orally, but they can be used via other routes. And now for IM dosing, lorazepam is preferred to diazepam for IM, for the simple reason that the absorption of diazepam from the muscle is very slow and erratic. You cannot trust the absorption. But lorazepam is quick, you know. So if you are giving IM, then lorazepam is better than diazepam. So these are the key points. Then some of them have long-acting metabolites. Take note of diazepam. When you look at the metabolic pathway, diazepam is here, and it is converted to nordiazepam or this metadiazepam, the same thing. You see that all this chlordiazepam would even be converted to this first and eventually to this. This metadiazepam is also active as a benzodiazepine metabolite. In fact, its half-life is 60 hours. So if you take diazepam, its half-life is long, but it's also going to produce a metabolite with even a longer half-life. So chronic use will typically lead to cumulative effect, hangovers and things, even after you've stopped taking it. Okay. Adverse effects, you know that already: drowsiness, sedation, psychomotor impairment, and gait impairment, ataxia. These are adverse effects if you are using the drugs as anxiolytics. Okay? Then these are problems. So the relevance: driving. If you take this, the residual symptoms can affect driving the next day. Okay? So these things should be clear to the patients. Then point number 2, anterograde amnesia. When you take a benzodiazepine, so long as the drug is in your system, memory storage is impaired. And the effect varies from one benzodiazepine to another. The most amnestic benzodiazepine is flunitrazepam. The popular brand is Rohypnol. It is an agent that has been used for date rape. We are familiar with date rape. Okay, so they will take this, put in the drink of somebody, and then abuse the person. And the person does not remember after recovery. I mean, what has happened, who is responsible, and those things. Because whilst the drug was in the system, it was interfering with memory storage. The person cannot remember anything. Okay. So all benzodiazepines have that tendency, except that it varies, the intensity varies from one agent to the other. Then paradoxical effects. You are giving the drug to treat anxiety, and the person is more anxious, becomes agitated, very talkative because of disinhibition. The person is irritable, easily angered, and is aggressive. Meanwhile, you are expecting your drug to produce the opposite of these effects, okay? So don't be surprised if you give a benzodiazepine and you are seeing paradoxical effects. It's because of inhibition of some brain areas that should not happen. The drug is to be avoided in the first trimester. It's a pregnancy category D agent. We know that there is some risk, but the benefits outweigh the risks if you have to use it. Then, tolerance, one of the downsides of benzodiazepines. When you use them for a while, you lose the effects unless you increase the dose before you can get the effect you start with. Fortunately, tolerance does not appear to affect the anxiolytic effects of the drugs, but anticonvulsants, sedative, all those things, tolerance will develop. Now to one of the most important points, abuse. Benzodiazepines are among some of the most abused agents that we have in our pharmacies. And people walk in and just buy occasionally, even without prescription. But the problem is that the benzodiazepines have some moderate tendency for addiction. So if you rank addiction between a scale of 1 for non-addiction to 5, the risk of benzodiazepine producing addiction is 3. Alcohol is 4. Okay? So it's a very serious thing. We should not play with it. The desirable properties are the anti-anxiety effects, some euphoria, and disinhibition that people get when they take it. Somebody wants to take it so that they can talk plenty. And they have some courage now to talk and say things that probably they wouldn't have said. Okay? And promotion of sleep. These are the desired effects. And they have found that the risk of abuse is highest with diazepam, alprazolam, and lorazepam for the simple reason that they have a quick onset. So as soon as the person takes the effect is there. So they appreciate the effect, and so they know that these particular drugs, will be helpful in the future. So they are stuck to it. Okay. So let's take note of that. Then the issue of dependence. When you stop benzodiazepines, especially abruptly after continuous use, you have withdrawal symptoms. Okay? For the short-acting agent, the symptoms appear within 1 to 2 days of withdrawal. For the long-acting ones, it can take up to about 7 days. And the symptoms are here. So you stop diazepam after you've taken it for a while, and you find that you are anxious, you can't sleep, you are easily irritated, you have muscle weakness, you have tremors, you have lost appetite. You see these things and you know that these are problems arising from withdrawal from the benzodiazepine. More serious things can occur, but less frequently, okay, including seizures. Okay. So how do you manage the withdrawal problems, you taper off the dose gradually. Okay, one study recommended a 25% reduction per week until you get to 50% of the dose. Then the symptoms become milder as you reduce them. So you are a bit more free to reduce by whatever rate you want. But commonly about 1/8 of that for every 4 to 7 days. For the long-acting ones, you have to taper over a longer period in order to minimize the side effects. And there has also been a recommendation that because the short-acting agents tend to produce a bit more severe withdrawal symptoms, so you can also switch the patient to a longer-acting one first before you taper it off. Okay, but there's a study recently that has challenged that. Then you can also use pregabalin, carbapenem, or propranolol, or even psychotherapy together with your dose tapering in order to minimize the symptoms as well. Now, take note that if a pregnant woman was taking a benzodiazepine, as we said, the child is benefiting. As soon as the child is born, the child has been abruptly removed, from the environment where it was benefiting from the benzodiazepine. So withdrawal symptoms will be expected in the child when he or she is born. Are you following? So that will have to be monitored. Okay. So to minimize the abuse and the dependence, it is advised that before you write a prescription of a benzodiazepine for anybody, you have to check whether the person has a history of alcohol or substance abuse, because they tend to abuse these things more. The risk is higher with these people. So you identify them and probably give them some other drug aside the benzodiazepine, because they have experience with substance abuse. Okay. Then you should also counsel the patient about the withdrawal symptoms so that they are prepared for it, and also that they don't stop abruptly. They need to be helped by the prescriber to taper off the dose gradually. The main interactions, the very dangerous ones for benzodiazepines is when they are taken with another sedative agent. Benzodiazepines are safe in overdose. You just sleep for a long time, but I mean, it is safe. You won't have respiratory depression and die in your sleep. But if you take the benzodiazepine with alcohol or barbiturate, then you are in trouble. Respiratory depression. So you sleep and die in your sleep. Yes. The other interactions due to enzyme inhibition and all that are not so much a big deal. In overdose, fortunately for us, there is an antidote, Flumazenil, which can be given to counteract the benzodiazepine effect. It only works for benzodiazepine toxicity. It doesn't work for barbiturate, it doesn't work for alcohol. It works only for benzodiazepines. But the downside is that it can also begin to stimulate, but it is countering inhibition. So it can also begin to stimulate if the dose goes higher. So arrhythmias and seizures can occur if you give too much of it. Okay. So finally, buspirone is only effective for generalized anxiety disorder. It's a partial agonist of 5-HT1A receptors. And it is effective against the psychic symptoms, just like the antidepressants. So that can be used, except that it doesn't work fast like the benzodiazepines. You take a few days to see its effects. Okay. The adverse effects are not many. There are only 3 popular ones: dizziness, nausea, and headache. Most of the problems you find with benzodiazepines are not there. It is also unlikely to be abused. Okay. Gabapentin can be useful for social anxiety disorder, pregabalin for generalized anxiety and social anxiety, quetiapine as an agent for treatment-resistant social anxiety, and then as I said about beta blockers for the management of the physical symptoms, particularly in performance anxiety. Okay. So thank you very much. If there is any question.
Thank you very much, Dr. Abuchi. I just checked my watch and it's past midday. Okay. So soon we should be preparing for Dr. Done, to come. So I think we are going to end here. Yes. Maybe again take some 5 minutes break while we get Dr. Done to come on board. But I want to say that we should be prepared to have a long day today so that we'll be able to finish by 11 a.m. tomorrow because there's a lot of things to cover. Okay.